Welcome back to the deep dive. If you're listening to this right now, chances are you're either deep in the trenches of board preparation or, you're a surgeon looking to sharpen your clinical acumen on high-yield topics. We are taking the massive mountain of textbooks and papers and distilling them down into the absolute essentials.
Right, we're cutting through the noise to get straight to the signal.
Exactly. Now, before we even open the first case file today, do me a quick favor. Press follow on whatever app you're using right now. We have a whole series of these revision sessions coming up covering everything from hand surgery to craniofacial, and you really do not want to miss them. Also, if you learn something new in the next 20 minutes, leave us a rating. It helps us keep these deep dives coming.
Yeah, and a quick heads up on the format for this one. This is a revision deep dive. We're covering the what, the how, and the core guidelines you need to pass the exam. But if you want the why, the actual analysis of the landmark papers, debates on surgical nuance, the evidence base, you need to get a premium subscription.
Yeah, absolutely.
That's where we host the Journal Club and the Clinical Cases episodes. They are separate from this feed.
That is where the real mastery happens. Also, we build this curriculum based on what you need, so if there's a specific topic you want us to grill next, leave a comment. But today we're tackling a massive topic in plastic and reconstructive surgery, facial nerve palsy.
Oh yeah, this is a classic board topic. It's the ultimate test because it bridges the gap between intricate skull base anatomy, neurology, and then complex microsurgical reconstruction. You can't just memorize a list for this. You have to truly understand the pathway.
So we're going to run this FRCS style, rapid fire. We'll throw the clinical questions and anatomical landmarks at you. You give us the high-yield answers and the rationale. Sound good?
Ready when you are.
Let's start at the very beginning. Anatomy. And I don't mean just the face. Take us intracranial.
Right, so you have to remember that the facial nerve isn't just a single wire. Intracranially, it has two distinct roots emerging from the pons. You have the facial nerve proper, which is your motor root. That arises from about 7,000 motor nuclei.
And the second root?
The nervus intermedius. This one is smaller, maybe 3,000 fibers. It carries the sensory and visceral components, specifically taste and parasympathetic fibers. They both leave the medulla-pontine angle and enter the internal auditory meatus right alongside cranial nerve 8.
Which is exactly why acoustic neuromas, or vestibular schwannomas, often present with facial nerve compression, right? Because they are roommates in a very tight bony canal.
Precisely. They're packed in there.
Okay, so they enter the temporal bone. This is the intratemporal course. For the boards, this is basically a localization game. If a patient presents with a specific deficit, you need to pinpoint where the lesion is along the track. Walk us through the branches from proximal to distal.
Think of it as 3 distinct stops. The first branch, coming right off the geniculate ganglion, is the greater superficial petrosal nerve, or GSPN.
And what's its job?
It's a parasympathetic secretomotor nerve to the lacrimal gland. It controls tear production.
So clinically, if I have a lesion at the geniculate ganglion or proximal to it, what do I see on the ward?
You get a dry eye, and you verify that with Schirmer's test, hooking the little litmus paper over the eyelid to measure the tear production.
Perfect. Next up.
The nerve to stapedius. This innervates the stapedius muscle, which stabilizes the stapes bone to dampen loud sounds. If this nerve is knocked out, that dampening mechanism just fails,
Resulting in
hyperacusis. The patient will complain that normal sounds like a door slamming or a phone ringing are painfully loud on that affected side.
Right. And the third branch, right before the exit.
The chorda tympani. It leads via the petrotympanic fissure, and it has 2 functions. It carries taste sensation from the anterior 2/3 of the tongue. It hitches a ride with the lingual nerve for that, and it provides secretomotor supply to the submandibular and sublingual glands.
Okay, so the nerve finally exits the skull at the stylomastoid foramen. Here is the vital distinction for the exam. If the injury is distal to this foramen, say, like a parotid laceration, what is the presentation?
It is a pure motor paralysis.
Yeah.
You spare taste, you spare hearing, and you spare tearing because all of those branches have already taken their exits inside the temporal bone.
Good. We are now extratemporal. What's the very first branch out of the gate?
The posterior auricular nerve. It runs backward to supply the occipitalis and the posterior auricular muscles. It's often overlooked by residents, but it is the first extratemporal branch.
Then the nerve enters the parotid gland, splits into the temporozygomatic and cervicofacial trunks, and fans out into the 5 terminal branches. I want to focus on the danger zones here. Talk to me about the temporal or frontal branch.
This is the one that keeps facelift surgeons up at night. The danger zone is defined by Patangi's line. You draw a line from 0.5 centimeters below the tragus to 1.5 centimeters above the lateral eyebrow. The nerve generally follows that trajectory.
There's a classic neurology trick regarding the forehead. Explain the difference between an upper motor neuron lesion and a lower motor neuron lesion in this specific area.
Oh, this is crucial for distinguishing a stroke from Bell's palsy in the ER. An upper motor neuron lesion, like a cortical stroke, spares the forehead. The patient can still raise their eyebrows.
And why is that?
Anatomically.
Because the forehead has bilateral cortical representation. The left side of the brain contributes to the right forehead and vice versa. So if one side of the brain goes down, the other side just compensates.
But a lower motor neuron lesion?
Like a cut nerve or Bell's palsy, that knocks out the final common pathway. The forehead on that side is completely paralyzed. So, simply put, stroke spares the brow, Bell's drops the brow.
Great rule of thumb. Moving down the face, zygomatic supplies the orbicularis oculi, buccal handles the buccinator and upper lip. Let's talk about the marginal mandibular branch. It runs deep to the platysma, usually just below the border of the mandible. Injury here is cosmetically devastating because it knocks out the depressor anguli oris. The patient cannot lower the corner of their mouth. When they smile or open their mouth, that side stays high, creating this very visible asymmetry.
And finally, the cervical branch supplies the platysma. Let's shift gears to etiology. We divide this into congenital and acquired. What is the most common cause of unilateral congenital facial palsy?
Birth trauma. It's usually mechanical compression against the mastoid process. Risk factors you want to look out for include forceps delivery, high birth weight, and primiparity, meaning first-time mothers.
What's the prognosis there? Does it need surgery?
Generally good. It is typically a neuropraxia, a bruising of the nerve rather than a transection. Most of these infants recover spontaneously.
Now, syndromic causes. Give me the high-yield summary for Mobius syndrome.
Mobius is rare and distinct. It's usually bilateral paralysis of cranial nerves 6 and 7. Because the abducens nerve 6 is gone, they have no lateral gaze. Because the facial nerve 6 is gone, they have a classic mask-like facies. They also frequently present with club foot or talipes equinovaris.
And Melkerson-Rosenthal syndrome.
You're looking for a classic triad here. 1, recurrent facial palsy. 2, chronic facial edema, usually of the lips. And 3, a fissured or scrotal tum.
Okay, moving to acquired causes. The big one, Bell's palsy. How do we actually define it?
Bell's palsy is a diagnosis of exclusion. It literally means idiopathic facial paralysis. It is the most common cause, accounting for about 55% of all facial palsy cases.
Patients always ask about recovery rates. What do the stats say?
The prognosis is generally favorable. About 71% recover completely. 13% have insignificant sequelae. But that leaves about 16% who will have permanent, significant dysfunction.
What is the treatment protocol?
Steroids are the absolute cornerstone. Prednisolone, usually 60 milligrams per day, started within 72 hours of onset.
And antivirals.
This is a really common misconception. There is no evidence for using antivirals alone in Bell's palsy. The data just doesn't support it.
However, that changes completely if the diagnosis is Ramsay-Hunt syndrome. Contrast that for us.
Ramsay-Hunt is herpes zoster oticus. This is a reactivation of the varicella zoster virus in the geniculate ganglion.
How do you spot the difference clinically on an exam?
Pain and vesicles. The patient will have severe ear pain, and you will see herpetic vesicles in the concha or the ear canal. The prognosis is significantly worse than Bell's. 50% of those with complete palsy fail to recover. Because this is a known viral etiology, here you do use a cyclover in combination with steroids.
Got it. And iatrogenic causes.
Parotid surgery is the most common culprit for surgical injury to the facial nerve.
Let's move to assessment. A patient sits in the chair. Aside from the obvious droop, what specific physical exam findings are you documenting?
You need a highly systematic, static, and dynamic exam. Check for forehead wrinkles. Check the Bell's phenomenon. When the patient attempts to close their eye, the globe should roll superiorly. If the lid doesn't close, you'll see the white of the sclera.
You also need to check the nasal valve, right?
Right. Check for nasal valve collapse on inspiration, and then analyze the smile vector.
This is where Rubin's classification comes in. What are the 3 types?
First is the Mona Lisa smile, which is zygomatic major dominant. The corners of the mouth pull up and out. Second is the canine smile, dominated by the levator labii. The upper lip elevates vertically, showing the canine teeth. Third is the full denture smile, where all muscles fire, exposing both upper and lower teeth. You need to know which one the patient has natively to plan a symmetrical reconstruction.
And we need to grade the severity. What's the gold standard?
The House-Brackman scale, it ranges from I to 6. Grade 1 is normal. Grade 6 is total paralysis.
The confusion for residents usually lies right in the middle. Distinguish grade the third from grade the fourth.
The tipping point is the eye. Grade 3 is moderate dysfunction, but the patient can still close their eye completely with effort. Grade 4 is moderately severe dysfunction, and the eye has incomplete closure. That functional deficit is the key differentiator.
The outline also mentions the Sunnybrook system.
Yes, Sunnybrook is a composite score from 0 to 100. It assesses resting symmetry, voluntary movement, and synkinesis completely separately. It is more sensitive and reliable than House-Brackman, but House-Brackman remains the universal language for reporting outcomes in the literature.
Let's get into the weeds of electrophysiology. ENOG electroneuronography. When do we do it?
Timing is critical here. You must wait at least 72 hours after the injury.
Or why 72 hours exactly?
Because of Wallerian degeneration. If a nerve is cut, the distal segment doesn't just die immediately. It can still conduct an impulse for about 3 days. If you test too early, you get a false negative. The nerve looks functional when it isn't.
And when is it too late?
After 21 days. By then, the muscle fibrillation and early regenerative attempts create way too much electrical noise, making the test useless.
So in that 4 to 21-day window, what are we looking for?
We measure the amplitude of the compound action potential and compare it to the normal side. The magic number is 90%. If there is greater than 90% degeneration compared to the healthy side, the prognosis is poor. 50% of those patients will not recover spontaneously. That is the threshold where you might consider surgical decompression.
All right, let's get to management, the reconstructive ladder. We start with non-operative and static. What is the absolute priority?
Eye care. Before you even worry about the smile, you must save the vision. If the eye doesn't close, you get exposure, keratitis, and corneal ulceration. You need lubricating drops, taping at night, and potentially punctal plugs to retain tears.
What about botulinum toxin?
It's very useful. You can use it to induce a protective boetosis, drooping the lid to cover the cornea. But perhaps more importantly, we use it on the normal side.
To treat the asymmetry.
Exactly. The normal side becomes hyperdynamic because it has no opposition. By weakening the normal side with Botox, you improve the overall symmetry and make the palsy much less apparent at rest.
Now, if we need a surgical solution for the eye or face, but reanimation isn't an option, maybe the patient is elderly or the prognosis is poor, what are the static options?
For the eye, gold weights placed in the upper eyelid are standard. They use gravity to close the eye when the levator relaxes. We also use canthoplasty, tightening the lower lid. Usually, a medial canthoplasty is preferred over a lateral tarsorrhaphy, just for cosmesis.
And for the rest of the face?
A direct brow lift is effective for clearing the visual field, though it does leave a scar. For the mouth, we use fasciolata or tendon slings to statically suspend the corner of the mouth, preventing drooling and improving the resting position, plus nasal batten grafts if there's valve collapse.
Now we enter the really complex territory, dynamic reconstruction, reanimating the face. There is a rule of time here that dictates our entire strategy. Explain that cutoff.
The critical window is roughly 18 to 24 months.
Why is that timeline so rigid?
It comes down to the muscle physiology. If the injury is less than 2 years old, the native facial muscles are denervated but still viable. They are just sleeping. You can wake them up with a new nerve supply. If it has been longer than 2 years, those Mutterem plates degenerate and the muscle turns to fibrosis. No amount of nerve signal will make them contract. You have to bring in new muscle.
Okay, let's handle the early phase first, less than 2 years. The muscles are good, but the nerve is gone. What are our options?
Direct repair is always the first choice. If there is a gap, we use a cable graft, typically harvesting the sural nerve or the great auricular nerve.
But what if the proximal facial nerve stump is just unavailable? Say it was sacrificed entirely during tumor resection. We need a nerve transfer.
Right. The workhorse here is the hypoglossal nerve, cranial nerve 12.
But the classic 12-7 transfer involves cutting the hypoglossal nerve. What's the downside?
It's significant. If you sacrifice the whole hypoglossal, you paralyze half the tongue. The patient suffers from hemiglossal atrophy, difficulty clearing food from the cheek, and real speech issues.
So how do we avoid that morbidity?
We use a jump graft. Instead of cutting the hypoglossal, we suture a nerve graft end to side on the hypoglossal nerve. We create a tiny window in the nerve sheath and splice the graft in. This allows axons to sprout into the graft to power the face, while the main highway to the tongue remains completely intact.
Let's talk about the cross-facial nerve graft, or CFNG. What is the specific advantage of this technique?
Spontaneity. This is the only technique that restores a true emotional smile. You are tapping into the contralateral normal facial nerve, so when the limbic system fires a laugh, the signal crosses the face and moves the paralyzed side automatically.
But it's not perfect.
No, it's not. It is a very long journey for those axons. They have to grow across the entire face. The signal can be weaker, and it involves two stages. This long delay brings us to the babysitter concept.
Oh, this is favorite exam topic. Unpack the babysitter procedure for us.
Ideally, you want the emotional input of the cross-facial nerve graft. But axons grow at 1 millimeter a day. Crossing the face takes 8 to 12 months. In that time, the native facial muscles might cross that 2-year threshold, atrophy, and die.
So you need something to keep them alive.
Exactly. You perform a partial hypoglossal transfer immediately. That provides a powerful, nearby nerve source to innervate the muscles and keep them bulky. That's the babysitter. At the same exact time, you place the cross-facial nerve graft. Later, when the cross-facial axons finally arrive, you hook them up. You get the preservation of muscle bulk from the hypoglossal, and eventually the emotional control from the cross-facial.
Brilliant. Now, let's shift to the late phase, more than 2 years, or congenital cases like Mobius. The native muscles are completely gone. We need a free functioning muscle transfer.
The gold standard here is the gracilis muscle. We take a segment of the gracilis from the inner thigh, along with its nerve and artery, and transplant it to the face to mimic the zygomaticus major.
We have two main ways to power this new muscle: two-stage or one-stage. Let's break down the two-stage procedure first.
This prioritizes spontaneity. Stage 1. You harvest a sural nerve graft, attach it to the normal facial nerve on the healthy side, and tunnel it across the upper lip to the paralyzed side. You just leave the end banked under the skin.
Then you wait.
You wait 6 to 12 months. You monitor for a tendinal sign at the end of the graft, tapping it to see if the patient feels tingling. That tells you the axons have made the journey. Stage 2. You bring in the gracilis muscle and connect its nerve to that cross-facial graft.
So the result is an emotional smile, but it takes 2 surgeries and over a year of waiting. Contrast that with the one-stage procedure.
In the one stage, you transplant the gracilis, but instead of relying on a cross-facial graft, you hook the gracilis nerve directly to the nerve to masseter cranial nerve on the affected side.
Pros and cons of going with the masseter.
Pro. It is one surgery, and the masseter nerve is incredibly powerful. You get strong movement, and you get it quickly, usually within 3 to 4 months. Con. It is not emotional. The patient has to actively clench their teeth to activate the smile. It requires significant cortical adaptation and motor learning.
Before we wrap up management, let's loop back to Mobius syndrome specifically. Why is the reconstructive strategy different?
Well, in Mobius, the paralysis is bilateral. You have no normal facial nerve to borrow from, so a cross-facial graft is biologically impossible.
So what is the donor of choice?
The nerve to masseter. It is almost always spared in Mobius. We typically perform bilateral gracilis-free flaps powered by the masseter nerves.
Wow, we have covered a huge amount of ground here. Anatomy from the brainstem to the superficial musculoaponeurotic system, etiology from birth trauma to herpes zoster, and the full reconstructive ladder.
It is a lot to digest, but for the exam, keep your algorithm really simple. Is the eye protected? Is the muscle viable? Is the nerve intact?
I want to leave the listeners with a final provocative thought regarding that reconstructive trade-off we just discussed.
The debate between the masseter nerve and the cross-facial nerve graft.
Right. As surgeons, we often idealize the cross-facial nerve graft because it offers that holy grail of an emotional, spontaneous smile. It feels physiologically correct.
But the reality is that the signal is weaker, the excursion is less, and the timeline is much longer. The masseter transfer, while technically unnatural because it requires clenching, provides a reliable, powerful, and symmetrical smile much faster.
So the question to consider and really to discuss with your patients is this: would you rather have a subtle smile that happens automatically when you laugh, or a strong, reliable smile that you have to consciously control? There is no single right answer, but understanding that trade-off is the mark of a mature surgeon.
Absolutely. The goal isn't just anatomical restoration, it's patient satisfaction.
On that note, we are going to close this revision session. This was the rapid-fire summary. If you want to dive into the actual papers comparing Masser versus cross-facial outcomes or look at the specific data sets on antiviral inefficacy, you need to subscribe to the premium feed for our journal club.
Yeah, that is where we get into the heavy evidence you need to argue your case in the oral boards.
Don't forget to rate the show, leave a comment on what topic you want next, maybe hand fractures or cleft lip, and keep studying. We'll see you in the next deep dive.